All right. Hello, everyone, and welcome to this month's Granite Peak Clinical Corner, where we're going to be talking about care plan development and implementation. The reason that picked this one is because care plan, the F tag 656, continues to be one of the top 10 cited tags across the nation. Um, and I have Carmen Taylor also on. She will be available to monitor the chat box and kind of let me know if there's any questions. And we'll just get into it. I know everybody's kind of interested in the like regulatory side of things, but I do have a section on here that kind of talks about, how to develop SMART goals, how to really put together a collaborative process for care planning. So let's get into it. The objectives here, we're going to recognize the importance of the care planning process, understand the regulatory requirements, understand the difference between treatment plans, care plans, and post-discharge care plans, view the care planning process as an opportunity for creativity, discovery, and learning for both the patient and the providers, match and use empowering techniques in the implementation of shared decision-making care planning process, acquire and utilize skills to enhance patient goal setting, view care planning as a dynamic process involving ongoing updates and evaluation. And the part that I think most people are interested in is I have some very specific, the kind of key clinical areas that are often heavy hitters for citations into this specific tag. So let's talk about the regulation first, 656. It says that the facility must develop and implement a comprehensive person-centered care plan that is based on an assessment, includes measurable objectives and timeframes, addresses medical, nursing, mental, and psychosocial needs, and respects resident rights. The care plan also has to include services to attain and maintain their highest practical well-being. That's the surveyor's favorite statement in the world. Services decline due to the resident rights refusals, PASSR-based specialized services, or rationale for non-agreement for utilizing those, and input from resident or their representative, including their admission goals and desired outcomes, discharge preferences and potential, any referrals and documentation of community return assessments. And all care plans are required to be culturally competent and trauma informed. So why does it matter? Care planning drives the type of and quality of care a resident receives. I know the running joke when I was a surveyor was, well, we just write care plans for surveyors. And really that is a disservice to a process that, we all spend quite a bit of time on in terms of the assessments and, the meetings with patients and families. So it's not just, a survey or document, but it really should, drive, like I said, the type and quality of care a resident receives. Incomplete or inadequate care plans can negatively impact quality of life and outcomes. And on top of that, we can get citations for it. Facilities must collaborate with residents and or representatives to align care with preferences and goals. So, what's the difference between a treatment plan, post-discharge care plans? A treatment plan is like the doctor's orders and recommendations with regard to their patient's medical care. The care plan is what's developed between the interdisciplinary team and the resident, which is guided by the physician's orders, the resident's goals, and their personal preferences. And the post-discharge care plan is that portion of the care plan that the patient will implement at home. It contains individualized instructions that the patient has collaborated to develop. Never should it just be us at the facility level deciding what is happening for these patients. It should be with input from the patients or the responsible party members. So formal written plans help organize the work of teams. They help patients to navigate the complexities of multidisciplinary care. And collaboratively by the health team, it bridges the doctor's orders and the patient's personal goals. So back in the day, a long time ago, kind of like whatever the doctor said is what went. And now, as things have evolved and progressed, patients are expected to be informed, proactive, and participate as a partner in their care planning process and their medical health and all of those things. So really, as a service recipient in nursing homes, they should lead the development of their care plans. And this, of course, is if they're all cognitively able to be a participant. And if not, then we do everything we can to involve people who are fully informed on what their preferences, their needs, their routines, their habits are. But really, we should be doing our best to, embrace what the patient brings to the table. So, person-centered care plan in action. The resident is the center of control. And in making the resident center of control, we have to use language to help make the resident the center of control. So, engaging them in discussions about the different parts of their care plan. I've been a part of care plan meetings where we don't even really talk about the care plan. We just say, "Is care going good? Okay, good. These are your medications. These are the treatments that we have on your orders." And there's not a real discussion around, maybe some complicated behaviors that the person is having and really engaging them. And sometimes it's really scary to have those direct conversations. But to do this in the way it's kind of formulated and set out in the regulations, and those are built on, best practices and lots of studies, it really should reflect what their daily routines are, their activities, their life history, what their communication preferences are, what is, culturally and personally meaningful goals for them. And this is across every care plan you put in place for them, whether it's for pain management or it's for activities. We should be having a discussion with the patients about what are their goals for their stay around that specific area that we're having a care plan about. So, both the patient and provider expertise is needed. Healthcare professionals are the expert on health practices. Patients are the expert on their life. And I find many times that we tend to put ourselves into situations with patients where we're telling them what to do. And it should be more of like us engaging them in terms of what, is what they want. What are their goals? What's important to them? What are they willing to do as part of their care planning process? What health actions can they take? And really, the team needs to think about that for the patient, information, because we can give a lot of information to them, may not be enough. So they might need skills and confidence in order to really participate fully in whatever the goal is that we're trying to meet with a care plan. So the role of the IDT in this whole process is to conduct comprehensive assessments that serve as the foundation for care planning and guide related discussions. We should be collaborating across disciplines to assess, plan, and implement and evaluate care. We should be ensuring a person-centered comprehensive care plan that involves residents, their representatives, and goal setting and care decisions. We should also be evaluating and reevaluating the interventions and care to ensure that they are and remain appropriate. So how do we build a goal-driven care plan? Goals must be supported by measurable objectives. So, using pain as an example, you might want to identify through the assessment that their goal is to not necessarily be pain-free, but maybe just to be at a 3 or below. For specific interventions, the goals must be supported by those as well. Like maybe we don't want to be woken up at 5 in the morning for a blood sugar. So maybe we need to have the timing of that blood sugar being taken a little later, and that we would care plan around that if that's outside of what is typically done or normally done. Bathing preferences is another big one that gets hit regularly. We should be trying to identify what is the bathing preference for that patient and then care planning around that accordingly. Um, so the resident assessment, MDS is one of those, but also facility assessments inform this process. So you should be using resident perspectives, and their own words are super important pieces of being able to individualize a care plan, which is the words that we're hearing all over the place when it comes to citations around care planning. We're not individualizing. Everybody's relying really heavily on the PCC library because it's easy and we have a lot of stuff to do. But you can use resident words from those assessments. I often find, especially in like activities, is one of the like places where they get really good information and it doesn't get kind of like pulled over to the activities care plan or to social services or even to like pain management for a non-pharmacological. But this is also the same for even like I've seen in pain management assessments where we get really good information about what works for them non-pharmacologically, and then it doesn't get carried over to the care plan because we're just relying on the canned PCC ones. So the examples that I have here is like resident says they love Hank Williams Jr., Don Williams, Dolly Parton, who are all kind of in the same genre. And the care plan says that they like country music. And the genres for country music are very different, right? So if we're getting this good information, let's pull it over so that if I walked into your building to provide care for your patient, would I know that like Hank Williams Jr. would be the thing that would actually calm them down without that information being in the care plan? Another example is that the family reports that the resident's routine was to have a cup of tea, sit in a rocking chair watching the late show before bed most nights, and the care plan just says offer relaxation before bed. Those are two very different things, and just offering relaxation before bed is wildly open to interpretation and not very individualized. So, also using the resident assessment to identify medical, functional, psychosocial, and cognitive needs that you would then integrate into your care plan, and also using resident strengths, preferences, and risk factors to guide care planning. And we do a really good job of identifying risk factors and the problems. I think in all of our assessments, they're not typically built out to identify strengths. So then that would rely on us in our assessment process to be asking around what the resident views their strengths are, what they feel good about, and integrating that into your care planning process. So we're going to talk about shared decision making. And generally, this is going to be something more for like complex behavioral issues, maybe a difficult situation, somebody's opting to stop treatment, that maybe is a life-saving, life-sustaining kind of thing. So like here is a process that you guys can use. And this is more of like for those situations that might take a little bit more time and need a little more attention. Like I said, more for behaviorally based type situations is where I might use this because it's a little more extensive and it might require a little more time, is kind of basically where it comes down to. So, shared decision making. It's a collaborative process where patients and clinicians work together to make healthcare decisions, integrating evidence, clinical expertise, and the patient's values, goals, and preferences and circumstances. So, I would say the IDT is looked at almost like as a consultant to the patient. So, they're helping to provide information, to discuss options, clarify values and preferences, and to support consumer autonomy. The goal is a person-centered supportive encounter which promotes the ideal conditions for an effective decision making that's going to lead to their ultimate goals to occur. And with that, we want to empower patients with information so that they have autonomy or control over healthcare decision making. So how does this support patient empowerment? Shared decision-making process, IDT are encouraged to think about and apply self-directed care, self-determination, and person-centered care plans. So when you go into your care planning meetings, are we really like taking into account these pieces of what makes the shared decision making for that patient? Or are we going in saying, hey, this is what we're doing for you, and then leaving it at that without any kind of dialogue or conversation? And for residents and families to participate fully as partners in shared decision-making process, they'll need information skills, and this is another important one, is confidence. And the IDT will also need confidence in terms of like setting realistic goals for behaviors that we want to change. If we don't realistically feel like we have confidence in their ability, then we need to reevaluate our approach to that shared decision-making process and that goal. So the steps in shared decision making are: one, recognition that a decision needs to be made; two, a statement of options as equal so that everybody at the table comes with an idea or multiple ideas and nobody is just, shutting them down right away, that we're going to consider and look at all options as equal. Exchange of information on pros and cons of all options, exploration of understanding and expectations, identifying preferences, negotiating options and concordance, sharing the decision, and arranging follow-up to evaluate the decision-making outcomes. So the very first piece is that recognizing that a decision needs to be made. So in a stage of change, in contemplation that both either the IDT or the patient are aware of a problem, but aren't sure yet what we need to do about it. So the empowerment piece of this is that it is something that the patient wants to change, and this can even apply to IDT. The IDT wants to change somebody in that, or a problem that they want to resolve. But ideally, we want to find, something that the patient wants to resolve in whatever might be a problematic situation. And I'm thinking of, patients who are refusing cares, refusing treatments, refusing to be changed, those who only let one staff member provide a treatment change to them, or somebody who is, yelling and being having a disruptive and to other residents around them. And I'm not talking about the ones that are cognitively disadvantaged that are having those issues. I'm talking about people who have the capability to understand that their behaviors are impacting people around them negatively. And we are trying to figure out a way to come to a goal that can resolve this issue. So, solution focused is focusing on what the person wants to achieve rather than what they want to avoid. So, when current approaches aren't working, that we explore alternative actions that move them towards their desired outcome. And in solution focused mentality is really identifying and highlighting the little wins that move towards that big goal as well. Instead of always focusing on what people are doing wrong, like what are they doing right? And it is a process shift when it comes to, developing a care plan. So the statement of options as equal. So at this point, each person will weigh a personalized set of pros and cons, choose from a variety of change processes, interventions, and choose among those strategies for combating specific temptations or behaviors. So the empowerment in here is that brainstorming offers multiple ideas for discovering new and creative possibilities. And you would engage everybody on the IDT team to come with an idea because maybe it's pain related or people aren't eating or something that like is behavioral that activities might have a great idea for. So, or that social services might, or that, even the wound care nurse or the infection control person might have an idea for that person. So that's why, like, from an IDT perspective, that everybody brainstorms and comes up with creative possibilities. And you have to go into it as a team with the intention that there are no right or wrong responses. All ideas are going to be accepted and believed to hold potential. That doesn't mean that you're going to implement all of them. It just means we're looking at what we have out there as possibilities and what might work for this patient for whatever the care plan issue is. The other piece is that there are always solutions, and falls is another one of those areas where we get called a lot and people are like, oh my gosh, I don't know what to do. I've exhausted everything I can possibly think of. But you have to go into it with a mentality of there are always solutions and there's always more than one solution. Um, and you'll find that too. So, like I said, really brainstorming and cutting across IDT lines to have everybody have some input can help with this too. And of course, the patient. So the exchange of information on pros and cons would be next. So supporting the accumulation of the personal reasons and benefits of the change, the pros, is necessary to shift the decisional balance from the costs of the change, which would be the cons. So the empowerment here is based on ideas generated from the brainstorm. Do any of the options seem workable for the individual's problem or issue? And then you explore those options together in detail. Exceptions for every problem exist, and once discovered, that can be used to build a solution in a different view, helping the person to select the change that will help them become more of what they like and what they want to see continue. So, generally, most adults do better when they have options and they have choices instead of being told what to do when it is a complex situation. The next stage here is exploration of understanding and expectations. In preparation, taking time to explore options and experiment can support the individuals to choose the plan. And by experiment, I don't mean you go out and use implement it right away. You can actually kind of walk through the steps like, hey, let's walk through what this might look like in terms of we're going to implement a new behavior management plan. For somebody who is, verbally cussing out other residents regularly at the dinner table. So what's our plan and how can we kind of talk through what might work for that patient? If we decided that we were going to have him eat dinner differently, at a different time or at a different location, like walk through what that might look like. Who's going to bring him in? Are other residents that he's already kind of triggered by going to be there? Is it going to be infringement of his resident rights? Like you would go through kind of all those steps to kind of see, is this really something that is going to move us towards the ultimate goal? Also, understanding that failure can be a part of process change. So there's often times where I will talk about doing a behavior management plan because that's something that surveyors will ask for residents who are having, non-harmful behaviors, but maybe that are bothersome to other patients. And so we talk about sometimes doing like, hey, is there a positive reinforcer for a resident, like exhibiting the behavior that we do want to see? And you have to walk the line, and like you're not just doing a token economy and treating them like a toddler, like I'm giving you a sucker for doing a good job today. That's not really exactly what we're talking about. But understanding that, like, if, we've decided that in this, week-long period when we have our normal day staff, that if so-and-so exhibits XYZ behavior, then he decided with his therapist and with us that he wants to have some extra one-on-one time with the activities playing a game. So if that's the case, understanding that when we put this into place, that there might be failure. And that doesn't necessarily mean that we just throw our hands up and that we're done. It might have been that week, and we need to take it into context of the bigger picture. Like, was it a bad day? Was it a bad week? Is it something that totally needs to be changed? And being able to kind of like address that and be agile around those things when it comes to our care planning process. Empowerment at this point is setting goals that are small enough to be accomplished, and usually in 1 week. So I use like 1 week as an idea. Like, could this person really be able to accomplish this in 1 week? If not, then maybe we need to drop it down to one day. Maybe it is something that could be in a month's time. Like whatever the time frame is, like you just want to have at least 70% confidence that that person is going to be able to meet that part of their goal, and that our staff, whatever our part is, can also meet that our part of the goal as well. So what will the change look like? If we're talking about solution focus, what does the change look like? How will things be different? And then examining the detail about how that change will feel, what will be noticed when it first occurs. And really, staff need to be well engaged in these kind of processes once you've identified your interventions, that everybody is able to kind of support and implement them. Identifying preferences, deciding when to change, choosing the plan, best tools, support for coping with setbacks. That's all should be individualized with resident preference as well. And then what are the goals and actions that we've taken to accomplish these? And then solution focused is instead, what would you rather have? If we don't have what you're meeting, what would you rather have done? What is like not working? And then how can you implement that? What will you be doing? And then, like just being really super positive and solution focused about it. Negotiating options. So at this point, all stages, change processes, putting the focus on either thinking or feeling or the behavior, doing optional techniques to be applied in that process when everybody's in agreement with the goals of that stage. And just know that like if the resident or the staff have real low confidence levels, that is an indication that as a team, we need to maybe look at renegotiating into a smaller step or a different intervention. Small changes lead to larger changes, facilitates an easier way and a simpler path to change. So, focusing on, smaller, pieces of this whole process, if it like, again, if it's behavior related, instead of just like, we're going to fix him or him or her from, biting, kicking, hitting out right now with this one intervention today, it's probably not realistic. So being realistic, and making sure that everybody feels like valid and a big part of this process. Okay, so sharing the decision would be that last stage of the change, solidifying the commitment to change, sharing the plan with the support network. So again, so that like all the staff are kind of aware of what the plan is. And that, if a resident is really bought into the goals, that they're excited about them, you would encourage them to tell their support people so that they can also provide additional support or accountability for it. And then arranging follow-up. So by nature of our business, we do generally follow up and review care plans quarterly. You might, in situations that maybe are more behaviorally focused and, problematic, that you might want to review, together at a more frequent, more frequent time frame, just to see if the goal progress is working, seeing if we need to brainstorm some more, and then moving forward from there. So developing effective goals that are client-centered. Action planning is kind of one of the first places that we start. So, an action plan is something that you or the resident wants to do, reasonably accomplished in a specific time frame, as behavior specific, answers the questions, what is happening, how much, when, how often, and really begins with a confidence level at a 7 or more for change. Otherwise, we need to renegotiate. So solutions are a type of goal to think about. Define what the client wants rather than what he or she doesn't want. Look for what is working and do more of it. If what the client is doing not working, have them or her think about doing something different with their input. And, like if you brainstorm, how can we get to yes in that situation for them? Solution-focused techniques help identify strengths to be built upon, promote expectations that small changes will lead to bigger changes, and instills hope that change is possible, empowers the changers. Um, so for well-defined goals, give a positive statement on what the person will be doing or thinking rather than what they will not be doing or not thinking, and work with them to describe in specific terms what they will be doing or what they want to have done, and use their words and languages as well. SMART goals is something that's pretty common out there. So when we're setting goals, you want them to be specific, measurable, attainable, realistic, and timely. Um, so here's some ideas for, how do we get to the SMART goal side of things. Brainstorming is one of those, like providing direction for that. Writing down, this is just kind of like the summary of everything we talked about to get to the SMART goals. And then problem solving. Is kind of like we already talked about this. If it's we find something that's working or not working, if it's not working, then we try something different, assess it, and try other resources, and then move forward from there. It is important to engage families and friends in the care planning process. Friends, if they're, appropriate. It helps with a person-centered approach. Loved ones often understand the residents' values and preferences and their life history best. It enhances communication and continuity. Family can bridge communication gaps, supports resident autonomy and advocacy because residents might defer their decision making to trusted family members. It often increases care plan adherence. So families who are engaged are more likely to support and reinforce care goals with the patients that you have. Promotes trust and transparency. And of course, it meets regulatory compliance, which does require that care plans be developed with input from the resident and with consent their representative. So I want to talk briefly about specific regulatory required care plans that do come up and end up giving us, problems when it comes to citations. So PASSAR is one of those. So all of this information is directly from the state operations manual. So the care plan must address any specialized services from PASSAR, and I always recommend to keep this a working document. So, and what I mean by that, so if PASSAR gives you a list of, 5 or 6 different things that we need to be integrating. So they need to do a, neuropsych eval, individual therapy, and go out into the community. And let's say that the person no longer wants to participate in individual therapy. What I recommend to buildings that they do is take that piece and then make it into the problem section. So, for example, patient Susie has a diagnosis of schizophrenia. PASSAR level 2 indicates that she should receive individual therapy. She no longer wants to participate. So that's on the problem section now. And your new intervention then becomes periodically reoffer mental health services or coordinate mental health services as, resident requests at that point. So that way, like, it is a working document and everything PASSAR related stays on that PASSAR care plan, whether you're doing it or not. So you don't have to go back and find, from 15 years ago, when their neuropsych eval was done. If there are any PASSAR recommendations that are not being followed, just make sure that they are care planned accordingly. And then this is a big note because I'm seeing this left and right in different states is when writing a PASSAR care plan, don't make the problem statement resident is a level 2 because a level 2 is an assessment and a resident is not an assessment. So instead, state that the resident has a level 2 related to a diagnosis of whatever it is. People are not level 2s. Cultural competency in care planning. So this is respecting and responding to individual backgrounds. Interventions must align with health beliefs, language and communication style, religious, ethnic, or social identity. So make sure that those things are included throughout the care plan. Trauma-informed care planning. So we need to recognize and respond to trauma impact. That means collaborating with residents and their support system to identify triggers, implement sensitive, individualized interventions, address trauma-related symptoms. And this is something that the regulations specifically expect that all staff are versed on. So your CNAs, and even your housekeepers, if they have interactions with these residents, will need to know what their triggers are and interventions. So with trauma-informed care, if you do have something like that, I highly recommend you pull that information over to their care cardexes. Hospice care plan development collaboration. So hospice care plans, a lot of times what I see is that we're not delineating services that hospice is providing in the care plans. And also, we're not identifying the hospice care provider or a contact number for them as well. So make sure that the name, provider, and the contact information is on the care plan. And then in that, you're going to want to say, CNA 2 to 3 times a week for ADL care bathing, RN 1 time a week for symptom management and as needed, social worker 1 time a month. You can essentially copy what the hospice care plan is and put it into ours. So we have that, you have to have that in there. Dialysis care plan elements that are sort of important to talk about is identifying your dialysis facility name, the address of the location, the phone number, the chair times, and what days of the week. On there, you also have to have your typical clinical stuff, monitoring for blood pressure, weights vital, symptoms, complications, site integrity. And you have to have a plan if you have a patient that's refusing dialysis or they've missed dialysis. You want to have what the chain of command is for missed dialysis, the criteria for what they're doing, why they're stopping, why they're terminating, what our protocols are for rescheduling. And then another important part of this is dietitian communication. The regulation specifies that our dietitians at the facility level need to be communicating with the dialysis facility dietitians. And you don't necessarily need to have all these things in the care plan per se, but you are going to want to put in there that they are coordinating communication and they are talking about these things and they're captured in their documentation. So the other thing that I didn't add as a little list on here that should have been a bullet point, and I apologize, is that if somebody is going out to dialysis and they are going to miss a meal or meds, that you have a plan for making sure we're sending meals with them or their meds, or they're getting them at the dialysis or somebody's feeding them so that they're not missing meals when they come back. So make sure you also have that addressed. This is not an all-inclusive list. These are just the things that, I consistently see throughout. Other care planning things to think about: behaviors. If behaviors are being tracked to justify psychotropic medication use, make sure those behaviors are clearly care planned, and vice versa. So a lot of times I'll see that care planned behaviors related to psychotropic med use are not actually captured on your orders for behavior monitoring. And then make sure that care plan has specific non-pharm interventions and confirm that staff are aware and trained to implement them. So these might be things that you also need to add to your CNA Cardex. Pain management, you want to make sure that non-pharm pain interventions are identified on that care plan, and then that staff are documenting when those approaches are attempted. And a lot of times I know people do that on the MAR, so I do understand that happens there, but also it can be done in progress notes. I also encourage people to look at the diagnosis list. So we do that a lot for care plan development. So if they had a stroke, we'll do a care plan for a stroke. If they if they have some like a fracture, then we'll do a care plan for that as well. So also look at that for the mental health diagnosis. So use that as a framework for developing individualized care plans. So I would go look at our PCC diagnosis list, see what the diagnoses are, and see what we need to have care plan. And if it comes down to like mental health, you're going to want to know what the signs and symptoms of that diagnosis look like for that resident, outline any indicators of decompensation, include pharmacological and non-pharmacological interventions. So kind of taking the same approach that we would with medical issues for mental health. The other thing that I would suggest you do is look at the orders and regularly review those to make sure that they're in alignment with care plans. So oxygen use, we should have an oxygen care plan. Weight management orders, like we have supplements, we should have a weight loss or an at-risk for weight loss care plan. Pressure ulcer treatment or prevention should be reflected in an associated care plan. Anticoagulant use, same thing. So I know that I'm going over, you guys, but I really want to get this. So it'll probably be like 5 to 7 minutes over. The post-discharge plan of care is another one that is specific. So this plan should include where the resident will live after discharge, follow-up care providers and their contact information. This one's huge. I see this all the time that it gets missed, that we're not putting in the phone numbers for post appointment, if the DME people, the home health agencies, like those numbers are important for people to have. We also need to have community care and support services, when and how to contact the continuing care provider, and also contact information for the facility. For residents discharging home, they need written instructions. They need to have those instructions, discussed with them. Ensure that information is shared in a language they understand. And then the documentation, that discussion must be present in the medical record. So making it real, implementing your care plan. Communicate the interventions to all departments. So integrate your care plan into your daily CNA task sheets if it's something appropriate for them, dietary preferences, therapy routines. Use shift handoffs and team huddles for consistency. So if you have a resident who's had new behavior that's come up, I highly recommend you go around to whoever is providing care for those patients and making sure that we review that care plan with them so that they can speak to it and implement it. Ensure that all direct care staff, including agency, are aware of key care plan elements. And then, this is especially important. Like if we're putting people on, one-to-one supervision or 15-minute checks or any of those things, I've seen a lot of citations recently where we are not doing a good job of getting that communicated to all shifts. And then it's resulting in citations because staff are telling surveyors, I don't know, I've never heard that before. So please make sure that you have some sort of system for communicating key care plan things out to the staff. Make sure that we're actually doing spot checks, that you guys are doing walking rounds, audits, and resident interviews to make sure that those things are actually happening that we've care planned. Documenting refusals, changes, updates in real time. Ensure the EMR alerts and task systems reflect current interventions. Reinforce that with ongoing coaching, quick in services, and include implementation review and QAPI meetings or IDT huddles if things are not going well. So dealing with refusals and updating the care plan. If residents are refusing anything, whether it's to attend a care conference regularly, or it's they don't want to shower, or they don't want medication, or they're refusing their food, whatever it might be, you're going to need to make sure that that is documented and that it's care plan. And then seeing refusals in progress notes should be a flag for staff to be like, oh, hey guys, do we need to actually care plan this? So make sure we are reviewing progress notes and looking for refusals. Your care plan must identify the declined service and the associated risk. It should reflect education efforts and alternatives offered. So I have a resident that doesn't want to wear their hearing aids. So my question to the staff was, did you offer a pocket talker or any other alternative? And a lot of times residents will say, no, I don't want to do that. I'm good. I'm like wherever I'm at, this is what I'm going to do. But we have to at least show that we have tried. And then again, with care planning, you want to periodically review it, keep that plan current and up to date. Make sure that when we're doing assessments that we're actually comparing it to the care plans. We look at the orders, make sure we're comparing those to the care plans, and then looking at diagnosis to see if anything has changed, updated, and comparing that to the care plans. And this is in addition to everything that the MDS, already kind of guides you to, care plan anyway. So that is what I have for you. Does anybody have any questions? Okay. Well, it doesn't sound like there are any, so I appreciate you guys joining. For those of you that are on, we are having a Director of Nursing boot camp that's going to be happening in Skokie, Illinois, which is outside of Chicago, August 12th and 13th. Today is the last day to register. This is something that we are planning to offer a few times over the year, where we won't be having one in Colorado in 2026, unfortunately, but we will be having one like on the East Coast, West Coast, and probably in the South. So be on the lookout for those. And if anybody wants to join the one in Skokie, we would love to have you. It's a small group capped at 50. And we have a few spots left. So anyway, otherwise, you guys are doing a great job. Keep up the good work, and thanks for joining today.